So induction therapy is kind of an interesting area. There are actually no randomized trials to suggest induction therapy works or not. In fact, we've just started the first randomized study for ATG, and it's taken us 10 years to organize the clinical trial because nobody wants to do it, and it's been hard to get the funding for it, but we just enrolled our first patient into this study. But if you look at the ISHLT database worldwide, only about half the centers really use any form of induction, and about 30% use an IL-2 receptor antagonist. Now it's only basiliximab, and about a quarter of the patients use ATG. Alemtuzumab, a anti-CD52 molecule, which kind of leads to prolonged lymphocyte depletion, was used for a little bit, but because of concerns for increased AMR, it's kind of fallen out of favor over a period of time. Now, this is a meta-analysis that was published 10 years ago when IL-2 receptor antagonists really initially were studied, and they looked at to see if there was any benefit with the use of an IL-2 receptor antagonist versus placebo, polyclonal antibody, or a monoclonal, such as ATG, or a monoclonal antibody. And really, there was no signal for benefit of basiliximab or an IL-2 receptor antagonist over any of these particular induction agents or even placebo. We have data with ATG to suggest that it may actually be of benefit in patients who are particularly high risk, particularly with who are sensitized. And this is our data showing that patients who received ATG at our center had a much lower risk of developing de novo HLA antibody. Now, we are not an induction center. We don't use induction for every patient, and we'll only use induction in the high-risk cohort. And despite the fact that we only use it in the high-risk cohort, our data showed that patients who received ATG had less antibody production than those who did not receive ATG. And the possible mechanisms for decreased antibody production with antithymocyte globulin is attributed to the fact that there may be abrogation of the T helper cell activity. There's B-cell apoptosis because the thymus has about 15% B-cells, so it's a polyclonal preparation that will knock out B-cells at the time of induction as well. There is some data to suggest that it reduces ischemia reperfusion injury, and that there may be upregulation of regulatory T-cells as well. This is alemtuzumab data from Jeff Tuderberg when he was in Pittsburgh, showing that overall survival was comparable with the use of alemtuzumab, although statistically p0.09 there was a signal for lower survival, but rejection rates were significantly lower in patients who received alemtuzumab. I showed this before in terms of the summary of clinical trials and efficacy of drugs in heart transplantation. And really, what I want to focus on is the observation that in the 3-arm study, the combination of maintenance immunosuppression that was shown to be most effective was a combination of tacrolimus with sirolimus with the lowest risk of rejection, followed by tacrolimus and mycophenolate, and cyclosporin and mycophenolate, which was associated with the highest risk of rejection. So when it comes to maintenance immunosuppression, we kind of have a good idea that TAC and MMF, which is what's most commonly used, is pretty good, but TAC and sirolimus may be a little bit better, albeit with all the issues relating to PSIs in terms of tolerance. It's important to note that statins are a very important component of post-transplant therapy because they're immunosuppressive drugs. My colleague John Kabashigawa did the first study and published in New England Journal over 10 years ago now, showing a survival benefit with the use of statin therapy in heart transplant recipients. But surprisingly, not only was there a decrease in allograft vasculopathy, as you might expect, but there was a decrease in rejection as well. And this data was also reflected in the European study using simvastatin. So here's a case of a 36-year-old with a postpartum cardiomyopathy, cardiogenic shock, impeller used. She has a PRA of 30%, creatinine of 2, CMV status negative. Managed to get to transplant with a CMV positive donor. The flow cross-match was negative. Patient got corticosteroids and ATG induction because she's sensitized, and received initial intravenous mycophenolate. Patient was maintained on Valsite due to this mismatch, trimethoprim sulfa and oral nystatin. Received statin therapy, tacrolimus and prednisone. Her creatinine improved to 1.4, and subsequently she was noted to have developed a de novo DSA to DQ7. And at 6 months, the patient was switched to everolimus, and low-dose prednisone was continued. Valsite prophylaxis extended to a year because of the mismatch status, and routine trimethylsulfa prophylaxis at 1 year. In the last presentation, there was a question as to whether everolimus should be used. I would caution that these drugs should only be initiated not at the time of transplant, because all the randomized clinical studies showed adverse events, particularly with increased mortality at that point. But they do have a use when it's used after 3 to 6 months post-transplant. So the question is, who should get induction? What type? What are the infection risks? And what prophylaxis should be used? And I would wager that we really don't have any evidence to suggest that any induction agent is better than any others. What I can tell you is that we spare the use of induction therapy in our most sensitized patients. So if the patient's sensitized or the patient has renal dysfunction, we will use induction therapy. If they don't, we will not use induction therapy. And the reason for that is that these agents are associated with a much higher risk of infection. And with regards to infection, prompt prophylaxis is really important, particularly if you have CMV mismatch. You want PCP prophylaxis on board as well. And we also use oral antifungal therapy with nystatin for the first 3 months post-transplant. Patients may need monitoring, viral monitoring post-transplant as well, particularly if they're not able to tolerate Valsite due to persistent leukopenia, for example. Then we will monitor them with CMV PCR, particularly if they're a mismatch. Overall, if the prophylactic regimen is there, then we found that infection is not a big issue for these patients, and most infections are manageable subsequently, even with patients who receive induction therapy, and even in patients who've received augmented immunosuppression with desensitization therapies pre-transplant or at time of transplant. Thanks for your attention.